When it comes to bugs and drugs, one of the problems we see in prescribing is that junior trainees have a tendency to respond to a presentation by reflexively choosing a specific antibiotic. The classic example is a patient who presents to the emergency department with a fever and shortness of breath and automatically gets moxifloxacin. Although this seems to work most of the time, this reflexive prescribing has significant problems with it. Reflexive prescribing locks the clinician into one set of resistance patterns. As resistance patterns evolve, the reflex choice may no longer work. Without a robust approach to selecting second and third line options, you get stranded. Patients with significant allergies can also pose a similar problem, eliminating your go-to antibiotic. The final point is probably the most significant. Reflexive prescribing is increasingly successful as you move to broader spectrum antibiotics. This actually reinforces habits of using broader spectrum and broader spectrum drugs when astute assessment reveals narrow spectrum options. This is a major public health issue and one for which we bear responsibility as clinicians. So what would I suggest? First, break this automatic connection from presentation to antibiotic selection. Instead, the presentation should lead you to a differential diagnosis and then a clinical diagnosis. Based on your clinical diagnosis, you should be able to generate a list of potential offending bugs. I call this the microbiologic differential. Once this is known, you can then generate a list of antibiotic options. This provides a basis for your antibiotic selection. It also provides you backup options when things don't work. Looking at this approach explicitly reveals how important the fields of microbiology and pharmacology, along with excellent clinical diagnosis, are to successfully treating infections. This video is going to go over the basic microbiology for clinical practice, and specifically bacteriology. The in-class session will then focus on clinical presentations, building on this microbiology and pharmacology knowledge to make appropriate antibiotic selections. So let's dive in. Micro 101. This is a very trimmed down summary of the major bacteria you need to know. We're going to focus on the gram-positives and gram-negatives. That said, you can see that the bugs in the right-hand column are all important pathogens, particularly for those going into family practice, pediatrics, internal medicine, and emergency medicine. But we'll start with the gram-positive cocci. Most slides I'll be showing you have a gram stain on the right side. I've included this simply because I'm a little old school. That said, you should be able to interpret preliminary culture reports that only describe a bacterial morphology. Our first here is group A strep. This is a common cause of skin infections like cellulitis, erysipelas, and impetigo, some of which actually don't even require antibiotics. Thinking about strep throat, or strep pharyngitis, this is another common group A strep infection. Scarlet fever is a variation of this we see in pediatric population. It is a toxin-mediated syndrome that sometimes goes with strep throat. You see here this diffuse erythematous rash. It comes with a papular quality that gives it a sandpaper-like feel. There are two important immunologic sequelae of strep infections: rheumatic fever, now rarely seen, and post-strep glomerulonephritis. It has been a common board question to know which of these complications can be prevented by antibiotics. Only rheumatic fever is preventable. Post-strep GN is not. Group B strep. This bug tends to affect people at the opposite ends of life, the elderly and the neonates, as well as pregnant people, that is, people who contain neonates. In neonates, it's typically vertical transmission during labor that leads to neonatal sepsis, often setting in during the first day of life. It can also happen within the first few months, obviously by a different mechanism. In the elderly, we sometimes see group B strep grow out in blood cultures without a clear primary source. Sometimes a group B strep pneumonia can be identified. Regardless, these infections are typically very responsive to antibiotics. Strep viridans. The big thing to know here is that if you see this in blood cultures, think endocarditis until proven otherwise. Streptococcus pneumonia, or pneumococcus. On gram stain, this appears as a classic diplococci. It can usually be identified early when present. It's the most common cause of community-acquired pneumonia. It's also the most common cause of meningitis, more common than Neisseria meningitidis. Other things to know, it can also cause otitis in children. Here's a bonus question. If you have a patient with suspected pneumococcal meningitis, aside from appropriate antibiotics, what other medication treatment up front reduces mortality in neurologic sequelae? If you said dexamethasone, you're right, and you get the bonus points, which mean nothing. This is to reduce the inflammatory response in the central nervous system to the infection and subsequent treatment of it. Staph aureus. Staph aureus causes injury by two main mechanisms: direct invasion of tissues, like we see in cellulitis, osteomyelitis, and endocarditis, and exotoxin-mediated disease, such as in toxic shock syndrome. When you think of staph infections, think collagen, structural tissues, bone, skin, joints. Although you can see it in other areas, such as the urine and central nervous system, these are virtually always secondary sites. You must look for a primary source of infection when you see these. Another key point: if you see Staph aureus in blood cultures, you must get an echocardiogram to look for seeding of the heart valves. Coagulase-negative staph. There are quite a number of coagulase-negative staph. We often chalk these up to contamination and ignore them. The key is knowing when not to ignore them. There are two main situations to think about active infections: when patients have lines or hardware, and in particular new hardware such as joints or a heart valve, and when multiple blood cultures are positive, such as 2 out of 4 or on multiple sets. In these situations, you must take coag-negative staph seriously. Enterococcus. As you might have guessed, Enterococcus is a gut colonizer, but it can cause problems in a few areas. The biliary tree is one. Enterococcus is often implicated in cholangitis and cholecystitis. Urinary tract infections are another. Another final one that can sometimes show up in board exams, as in real life, is a patient who gets endocarditis after a prostate procedure. TERPs can cause an enterococcal bacteremia that leads to seeding of the valves. Watch out for this. It's of particular importance to recognize that Enterococcus is naturally resistant to cephalosporins. You need to keep this in mind whenever you're choosing ceftriaxone or cefazolin, for example, in treating pyelonephritis or cholangitis or cholecystitis or endocarditis. Make sure you have Enterococcus lurking on your mind in these situations. A cephalosporin may be the correct first choice, such as in pyelo, but you need to be ready if it's not doing the trick. And those are your main gram-positive cocci. On to gram-positive rods. There's actually not too much to worry about here. More often, these represent contaminants that come from soil, but there are a few you need to be on top of. Listeria. First is Listeria monocytogenes, or just Listeria. This is an opportunistic infection that is uncommon, but a big problem when missed. Listeria meningitis is potentially lethal, and at-risk populations need to be identified whenever meningitis is suspected. These include neonates, the elderly, and immunocompromised patients, including pregnant patients. Most commonly, Listeria will cause a diarrheal syndrome. This is often the source, which can lead to bacteremia and sepsis. The main source is typically food, and in particular, unpasteurized dairy products. This is actually the reason for the recommendation to pregnant women to only consume pasteurized products. Important is to remember that the treatment of choice is ampicillin. Septra is also effective, but remember to avoid using Septra in pregnant patients because it inhibits folic acid metabolism. Clostridium. The other important genus of gram-positive rods to know is Clostridium. C. diff, you've all gained extensive experience with by this point. Clostridium perfringens is a causative bug in gas gangrene, illustrated here. Clinical features include crepitus with subcutaneous air on X-ray, rapid extension of a necrotizing cellulitis, and foul-smelling wounds. This is a surgical emergency. I would strongly caution any unseasoned clinicians against ruling out gas gangrene or necrotizing fasciitis based on their own clinical impression. This is one consult question you can't get wrong. Finally, Bacillus is another genus of gram-positive rods associated with disease. Probably the most common is Bacillus cereus, or B. cereus. This generally causes an enterotoxin-mediated gastroenteritis. The classic source is fried rice at a buffet that has been sitting out there just a little too long. Two forms. A predominantly vomiting form of Bacillus cereus starts shortly after eating, typically within 1 to 2 hours, but even as late as 5 hours. There's also a diarrheal predominant form that starts just a little bit later, typically in the 8 to 16 hour range. The important point to remember here, because these are toxin mediated, you don't need to treat with antibiotics. More rarely, bacillus can grow in blood. Usually it's just a contaminant, but if you suspect it is not a contaminant, get ID involved. Bacillus culture contamination versus true bacteremia can be a very difficult clinical question to sort out. Get help. And that's all for the gram-positive frauds. On to gram-negative cocci. There's just 3 main ones I want to bring up: Neisseria meningitidis, Neisseria gonorrhea, and Moraxella catarrhalis. First, Neisseria meningitidis. Meningitis caused by Neisseria meningitidis can present less classically than pneumococcal meningitis. Although neck stiffness, fevers, and altermentation still occur, the complete triad is only present in about a quarter of patients. There are a few clinical features that help distinguish this as a causative agent, though. First is the petechial rash, sometimes confluent, forming macules. This comes when patients get bloodstream dissemination of the infection. Second, patients typically have profound myalgias with Neisseria meningitis. The thing is, when you hear rash and myalgias, your natural response is virus. But when the presentation suggests a CNS infection, you have to consider Neisseria. Third, these patients often develop profound hypotension that is typical of gram-negative sepsis. The other key clinical characteristic of Neisseria meningitis is the population that gets it. Typically, it's seen in situations of large groups cohabitating, college dorms, military barracks, situations like that. If you see a question on a board exam in which the patient comes from that population and presents with a meningitis type picture, think Neisseria. Neisseria gonorrhea is the next gram-negative cocci. This causes the typical discharge and dysuria that comes with gonococcal urethritis. In women, it can also cause a cervicitis, which can progress to pelvic inflammatory disease and sepsis when not treated early. Gonococcus should also be considered as a sexually transmitted cause of pharyngitis. One important note: Gonococcus is developing increasingly robust resistance. We're now seeing strains in some regions with resistance to penicillins, cephalosporins, tetracyclines, fluoroquinolones, and macrolides. Other manifestations that also have a habit of appearing on exams are septic arthritis and neonatal conjunctivitis. When you see these, think gonococcus. The final gram-negative cocci is Moraxella catarrhalis. Briefly, this bug is a common cause of COPD exacerbations, as well as a cause of otitis in children. Depending on your laboratory, it can often be ignored and treated as normal flora in the upper airways. However, if you allow sputum cultures to grow 48 hours or longer, they can often pick it up. Our final category is gram-negative frauds. I divided these into respiratory, GI, urinary, and hospital-acquired gram-negative frauds. Let's start with the respiratory. The first big respiratory gram-negative fraud is Haemophilus influenza. It comes in a variety of styles, but the 2 key classes are encapsulated and non-encapsulated. Overall, thinking about areas that Haemophilus affects, just think of airways from the ears and sinuses through the larynx into the lungs. This covers the bulk of the areas where you're going to see it as a pathogen. In addition, and especially in infants, the encapsulated type can cause arthritis and meningitis. These are decreasing significantly with the Hib vaccine, but don't forget about them, especially in your asplenic patients. Other common respiratory gram-negative frauds to think about include Klebsiella and Legionella. Klebsiella pneumoniae is a gut colonizer and a common cause of urinary tract infections, but it can also colonize the upper airway, often in healthcare settings and ICUs. An aspiration event or intubation predisposes to it causing a pneumonia. a particularly nasty pneumonia. Think about it also in patients with alcoholism, as well as those who have significant healthcare exposures, especially those intubated. Legionella. Legionella is an atypical gram-negative rod that was first recognized after an outbreak in 1976 at a Legionnaires' convention in Philadelphia. 221 people got sick and 34 died. The disease presents with symptoms of pneumonia, including fevers, cough, shortness of breath, and sputum production. But in addition, patients also often have GI symptoms, including vomiting and diarrhea, as well as neurologic symptoms such as confusion and ataxia. One particular finding in Legionella that is also seen in typhoid fever is a dissociation between the fever and the heart rate. Normally, fever is associated with tachycardia, but in Legionnaire's patients, they often have a relative bradycardia. This is actually surprisingly specific for Legionnaire's and typhoid fever. The key points on Legionella: it presents with respiratory, neurologic, and GI symptoms. Chest x-ray shows a lobar or multilobar pneumonia, and it requires treatment as an atypical cause of community-acquired pneumonia, typically involving a macrolide or a respiratory fluoroquinolone. The enteric gram-negative rods. Diarrhea is the common presentation. Two major types, enterotoxic and enterohemorrhagic presentations. Enterotoxic diarrhea presents as large volume watery diarrhea without blood and mucus. It's generally self-limited without significant complications. Major causes are E. coli and Salmonella. Enterohemorrhagic presents with bloody, mucousy diarrhea and severe crampy abdominal pain. This is a much more significant presentation and can be complicated by hemolytic uremic syndrome and even death. The typical sources are undercooked beef or contaminated water supplies. E. coli H7O157 and Shigella are your main culprits here. Salmonella typhi is the cause of typhoid fever, again related to the ingestion of contaminated food, more commonly seen in developing countries. Major symptoms are abdominal pain, fevers, again a fever out of proportion to heart rate, along with altered mental status and liver injury. Be aware, diarrhea is not typical with typhoid. It's really the crampy pain and the fevers that patients complain of. Look for a travel history in the past month. There's typically about a 1 to 3 week latency from exposure to onset of symptoms. Moving on to urinary gram-negative rods. I don't want to spend much time here on urinary bugs, but there are a few essential points. First, the urinalysis does not diagnose a UTI. Second, a positive urine culture does not diagnose a UTI. You diagnose the UTI. Look for the classic symptoms of dysuria, the need to void despite an empty bladder, and frequency. These symptoms, this is a UTI. Get the dipstick, get the culture, but in this context, a positive dipstick or culture supports your clinical diagnosis. They're often more helpful, actually, when they're negative, and other causes of cystitis need to be considered. In addition, you need to know what constitutes a complicated UTI from simple cystitis. Complicated UTIs, UTIs in men, in patients with abnormal urinary anatomy, UTIs with a fever or leukocytosis, or the presence of a kidney stone, patients who are catheterized, and finally, pyelonephritis. These are all complicated urinary tract infections. They warrant slightly longer antibiotic therapy. Finally, two important nosocomial gram-negative rods, Acinetobacter and Pseudomonas. Both nasty buggers. Acinetobacter. This is an increasingly recognized cause of healthcare-associated and specifically ventilator-associated pneumonias, as well as sepsis. It has the ability to contaminate lines, tubing, and other hospital equipment. Further, it can survive if contaminated surfaces are not very thoroughly disinfected. Another problem is that it develops resistance fairly rapidly, and even when it's a sensitive bug, it has limited antibiotic options. Thinking about the future, multi-drug resistant Acinetobacter is going to present a major problem for critical care units. Pseudomonas. Pseudomonas is another challenging bug to which resistance emerges fairly quickly. Again, typically there is a healthcare associated exposure, such as ventilators, but in addition, it's often a pathogen in diabetic soft tissue infections, particularly in patients with poor diabetic control. When you see it in diabetic soft tissue infection, it's typically after recurrent infections at an ulcer site, deep invasive wounds with foul-smelling purulent discharge. In patients with cellulitis who have underlying diabetes, the common pathogens are still common pathogens. But in these more invasive forms of cellulitis and soft tissue infections, think about Pseudomonas. The final population you always need to think about Pseudomonas in is the cystic fibrosis patients. They will often present with pseudomonal pneumonias that require extensive treatment to clear the infection. Okay, that was a whirlwind tour of some major bugs. Remember, this is an incredibly superficial overview. There are many bugs I didn't go over, in addition to not covering spirochetes, mycobacteria, viruses, and parasites. This has to be something for which you have a framework to think about these things and a plan for ongoing learning and education.